So our poster tomorrow is really related to us understanding the real-world evidence of how ADHD medications are used in adult ADHD. So it's a poster that we wanted to look at from the current database of adult patients, and we were able to look at about 206,000 patients with adult ADHD, and there were some very good learnings from that poster. First is they are being treated for adult ADHD, and 50% of those patient population are females. The second key learning is when they are being treated, over 50% of them happen to be on a monotherapy. 30% of them are, or over one third are around adjunctive therapy. And that really leaves us to understand that there's an unmet need of those folks who are on adjunctive, that they're taking it for longer duration. So the unmet need exists in that ADHD population for adults. You know, Shire's been committed to a lot of areas of different formulations. We're working on our development program now to see for a longer duration product available. So we're working on a development program for there. But we have to assess the unmet need first, right? I think that's important. Adult ADHD is the same condition as pediatric. It's just the nuance around diagnosis is something the DSM in 2013 have helped us understand the criteria, because you may not see an adult jumping from chairs to chairs. So the fidgety, the hyperactiveness looks a little bit different from the adult's perspective than the child's. So understanding that and showing what that phenotype looks like has been very helpful from 2013 DSM-5, where now clinicians are able to associate what an adult ADHD looks like. Obviously, the criteria are the same for ADHD diagnosis. There are 6, so you have to have either the 6 symptoms of inattention or the symptoms of hyperactivity and impulsivity to be qualified, and you have to have a functional impairment, right, to be able to diagnose with ADHD. In adults, the nuance is that you have to make sure that one of the 5 symptoms, because they're not always able to recollect some of the symptoms, and that's why DSM-5 has made a corrective action of recollection age of 12 instead of the last time when it was 7, because how many of us really remember things 7 and under at that time? There are very few medications available out there in terms of the stimulant market, the non-stimulant for adult ADHD. There's currently the same market available for methylphenidate and amphetamines and the non-stimulants such as Strattera out there for the adult ADHD. But we do know, just like in pediatric, the market is diverse, but also the unmet needs still exist. There are patients that may need certain durations, longer, shorter, and what happens is for the physicians, if they have enough armamentarium in their toolkit, I think it really helps bring those armamentarium to the right patient. Most of the physicians that treat these conditions are the adult psychiatrists, but they're also the physicians who see the primary care physicians who see these patients. And some of them are used to treating ADHD, and some of them are not. So there really becomes a little clog in terms of the ones who are not used to seeing the ADHD patients to send them back to the adult psychiatrists. For someone who's worked in other areas of the disease, I think the disease of medicine or the medicine evolution is really helping us as we assess, have new skills, have DSM-5 to give us phenotypes of what adult ADHD looks like. I think the recognition is increasing because it's been there. We just didn't have the right evidence to be able to tell that. And that happens in multiple sclerosis, it happens in many other disorders. The more we go over the scientific evolution, get better in our capturing of these symptoms, the better we get into the awareness. And the same thing happens with adult ADHD. So first of all, mental health. has always had stigma attached to it. More importantly, anything that starts at the neurodevelopmental disorder level, even with kids, the stigma just stays for so long in their lives. For adult ADHD, what has become a challenge is there were many kids who were not either diagnosed appropriately when they were kids, or finally realizing that they did have these symptoms, they just did not have the means of diagnosis. So like I said, the physicians always were looking for someone who was jumping from seats to seats, and these adults don't do that in their office. So now they're able to really associate that the adults don't have that type of hyperactive. They really have what we would call anxiety around, or anxious symptoms around their fidgetedness.